Thank you very much. Heart's tiny highways. So the mystery of the coronary microvascular dysfunction. This is what you see in the daily Cath lab day, but in reality is the picture in the left is what it counts. 80% of the blood flow to the myocardial cells comes from the microvascular site. So the epidemiology, now we know that's important. Now, is it common? Epidemiology of the chest pain with no coronary artery disease, obstructive coronary artery disease, 50% of the patients with the chest pain who have, it goes to the Cath, they do not have obstructive coronary artery disease. Many of these patients are young, mean age of 49, females, predominantly 41%, more than male in 8% of the cases. 9 to 14% of the acute non-ST elevation MI ACS patients do not have obstructive coronary artery disease. So let's go to this just to understand what the normal structural and functional of the coronary micro and macrovascular. The epicardial arteries are the one that we see in daily activity. And in the cath lab activity, and then it goes to the pre-arterioles and then arterioles. And if you notice this, that the metabolic, here there is a metabolic control and regulation of the flow distribution, and that is major of the interaction with the endothelial and the endothelial function. So if you go and you find the total resistance, if you notice the total resistance, it goes from 5% in the arteriole because of the size are big to goes to in the arteriole in the arteries in the epicardial arteries is 5% and is 60% in the arterioles, and the capillary is just an exchange site. So what is the coronary microcirculatory dysfunction? It can be divided to two things, vasomotor subtype and the structural subtype. The vasomotor subtype, again, to endothelial dysfunction and vasospastic angina, and the structural subtype with the microvascular angina. Now, these are like fancy names, and we can talk about it. So I know this is a crowded slide, but epicardial arteries, the thing that we can see is the two things in here, the epicardial spasm and the myocardial bridge. These are common things that we see and we have our own impression about. So let's go to the microvascular bit. So this is what happens in the rest and in the stress. So high vascular tone at rest. So we're talking about tone. Have a high vascular tone at rest and low vascular tone at stress. What results of this is a normal CFR and normal myocardial resistance. Now go to find out about the coronary microvascular dysfunction. This is the structural subtype and this is the functional subtype or the endotype. So what happened to the structural, that the vessel at rest is high tone, the same as the normal, and it has a high vascular, but it goes to the stress or the hyperemia stage, and then the tone will stay high. So the difference between going from high to low, it is here, there is an abnormality in here. And that's the structural, if you want to think about it or remember it, is the inability to dilate. That result of a low CFR and high IMR. And now the functional endotype, this is the structural is an ability to dilate. The functional is exhausted dilatory capacity. So it's supposed to be high vascular at rest, vascular tone at rest, and low, this is normal, and the low at stress. Now in the functional endotype, it's a low vascular tone at rest, and it is a low vascular tone at stress. And this is basically it's an exhausted subtype. So this is just, and in here that you will find that the IMR is normal, the CFR is low. Does it matter? It does. And I can prove to you that it does. So where is the CFR, what does the CFR look at? So it looks at the vessel from the tip of the catheter all the way to the capillary or the microvascular bed. And all of that is included in the CFR. Basically, the CFR, there's two ways to figure it out and to calculate it. One is either time or velocity, but we will not go into this because now it will get boring. So what is the abnormal CFR? Value and this value is get from the thermodylation derived CFR. Recent meta-analysis, 79 studies shows that the abnormal CFR that's less than 2 has higher incidence of all-cause mortality and higher incidence of MACE. And that is an eye-opener. And now what about the IMR, which is the index of myocardial resistance? The abnormal IMR indicates abnormal circulatory function, microcirculatory function. So let's see in the other publication, anyone studied this to find out if it's important? Yes, IMR predict clinical outcome after STEMI, and if the patients with normal IMR have significantly lower rate of death or rehospitalization of heart failure. Number 2. The patient with no coronary artery disease and obstructive coronary artery disease, both an elevated IMR and reduced CFR, had worse outcomes. Third, in cardiac transplant patients, IMR is independent predictor of mortality at 1 year. So it is important. But if you go to the literature and you find the Japanese, they are interested in this, and they did it post-rotablation, and the IMR stayed high till 6 weeks after the rotablation, and because of the debris and the microvascular activity. So just to go through this for one more time, CFR, FFR, FFR and RFR, it checked on the epicardial vessel or the bed, and the CFR, it goes from the tip of your catheter all the way to the microvascular thing. The specific thing to the microvascular bed is the IMR, which is the index of myocardial. So let's get these two numbers are very important. CFR less than 2, IMR more than 25. Easy. Okay, this is about the, is it recommended or is it in the recommendation? So guideline-based CFR or microvascular resistant measurement should be considered in the patient with persistent symptoms with no obstructive coronary artery disease, and that's a class 2A. So it's not bad. Okay, so let's go to this. Please tell me if, okay, I have 3 minutes only, okay. So let's go through I think this is very important to look at. So invasive coronary artery, the coronary angiogram shows no obstructive coronary artery disease, and then the adenosine and the FFR is 0.84, CFR is 5.3, IMR is 9. This patient went in the acetylcholine provocation test, and it resolved that this is a vasospastic angina. What do you need to tell him? Quit smoking, give him calcium channel blocker, long-acting nitrate, and lifestyle modification. What about this one? The microvascular, now they went into the coronary angiogram, shows no obstructive coronary artery disease. Coronary CFR shows an FFR of 0.95. CFR, remember the 2.5? It's 1.3 here, and the IMR is 333. And in this case, because there is a protocol to go through this patient has a microvascular angina. This patient will get a calcium channel blocker, beta blocker, lifestyle modification, and cardiac rehab. And consider ACE and statins because of what I've showed in the literature that the mortality benefit. And the other one that we went through this So 1, coronary angiogram, 2 is the microvascular assessment, 3 is the acetylcholine provocation test, and then you say that there is non-cardiac chest pain. I don't think that I have a lot of time, but I will show you this. This all of the best thing in the literature about the microvascular assessment is the Carmichael trial. And it is a randomized 151 patient, angina with no obstructive coronary artery disease. The intervention is invasive coronary functional guided care, the one that I showed, and versus angiographic guided. And the linked diagnosis is microvascular angina, vasospastic angina, or non-cardiac, the way that I showed. And you can see the main result is the sustainable benefit of improved angina and quality of life. So that is good. I will not exhaust the time with these cases. So when you get into the management phase of the subtype management, the structural coronary microvascular dysfunction, treatment aim, reduced myocardial oxygen consumption. Treatment, beta blocker, and aggressive cardiac risk factor modification. And the second one is the vasomotor coronary microvascular dysfunction and the endothelial dysfunction in the vasospastic angina. Treatment aim is control vasomotor tone and promote normal endothelial function. And the treatment, calcium channel blocker, and very liberal doses, and ACE inhibitor and statin. And I will jump the cases. I will show you one case. I'm very interested in this, so can you give me 1 minute? So when you do this, just a minute. When you do this, you get referred many of the cases.
Can we give 1 minute, please?
You have to be careful that you go through the protocol per se. Just don't forget that the angiogram, it is important to start with. I have seen cases that has a flow-limiting stenosis, epicardial stenosis, and there is other thing that we check. So, like for example, this one, positive MPI, her CFR shows 1.9, and the IMR is 29, and this lady was treated, asymptomatic now. She said that the only thing that treats me well, that I have a comfort of the diagnosis. I know now what is my diagnosis, and that is major. It's very important. And by this, I thank you all.
Thank you.